Very frustrating. So, all right. Everybody can see that pretty good? All right. So, I put in some statistics here. Each year, EMS personnel respond to over 30 million calls for assistance in the United States, and they have a rate of occupational fatality comparable to firefighters and police, and a rate of non-fatal injuries that is higher than the rates for police and firefighters. All right, so we get injured more than police and firefighters. In Australia, there is no occupational group that has a higher injury or fatality rate than EMS personnel. We have a rate of occupational violence injuries that is about 22 times higher than the average for all workers. So more than one EMS provider in the United States is killed every year in an act of violence. All right, and I found those when I was looking up some data. I found those statistics to be, really troubling. That's quite scary. So to know that. All right. So classroom instruction really doesn't do it justice. Every year we have an increasing number of violent acts against pre-hospital providers. If you check newsworld, emsworld.com, in any given week, there's likely to be at least one report of an attack against a provider. Current reporting systems are truly underreport the violence that occurs because there's no national reporting system for EMS providers to report verbal harassment or violent acts. And one study that I found showed that violence occurs in one form or another on 8.5% of all EMS responses. And the on-scene violence is directed toward an EMS provider in over half the cases. Patients are responsible for that violence 89.7% of the time. And that's actually from a study I found on PubMed. They've actually been studying it at like that level. So, and I had to insert some interesting pictures because, it's fun. So, Occupational Safety and Health Administration recognized that increased violence risk coming from an increased prevalence of handguns in the patient population, an increasing number of chronically ill mental patients, increasing gang activity, increased numbers of drug abusers, low staffing numbers, only 2 on a scene, isolated work environments like a private home, limited backup capabilities, and limited communication equipment, only 1 handheld radio on a scene. So this is what OSHA is saying is increasing our risks when we're on scene and dealing with potentially violent people. All right, so there's this thing, and there's a book. It's called Essentials of Aggression Management in Healthcare. It's a really, really good book. I recommend everybody read it. But he has this thing called the aggression continuum. So identifying the signs of an aggressive patient is an essential step in protecting yourself from harm. So in addition to identifying it, it's also important to determine where on that continuum the patient is. So there's 6 different phases that he identifies in an aggressive patient. And they progress through this behavior. So each phase builds upon the responses in the prior stage and then escalates the seriousness of the situation. So you have 1, which is what everybody is most of the time, calm and non-threatening. Right? 2, verbal agitation. 3, verbal hostility. 4, verbal threatening. 5, physically threatening. And then 6, physically violent. So we're going to go through these 6 stages real quick and kind of describe what they are so we can kind of recognize where some of these, and we can pick up some behaviors that might help us clue us in as to where your patient may be on this continuum. So phase 1, calm and non-threatening, okay? People go through life every day, calm, non-threatening. They think logically, they respond appropriately, they interact with the society in a socially acceptable way. As a pre-hospital provider, it's our goal to keep and or return patients to this phase whenever possible. And that last statement is probably the most important. It is also essential to remain here as a provider. We need to remain calm and non-threatening. Phase 2 is verbally agitated. Many people experience phase 2. It's fairly regular response to anger. They use words and phrases to express their displeasure. They have a strong tone of voice and speak louder. In phase 2, anger is not directed towards any individual or group of individuals, but the situation itself. Okay? So the example we have here is consider a situation where a teenager has been in a motor vehicle crash and they are visibly upset and worried that my dad is going to be so mad when he sees the car. That's an example of verbally agitated. Right? Most often, people that become verbally agitated can go back to phase 1 with little to no help from anyone else. Then you have verbally hostile. When individuals are upset over a situation, they become so angry that allowing them to vent and normal calming efforts fail to have an impact. They have advanced into phase 3, and they're considered verbally hostile. These individuals are so overcome by their anger that they lose the ability to converse about anything else. So they will not be able to talk about their own health or injuries because they're that upset. The anger is a distraction. It still isn't being directed towards any single individual or group. However, it continues beyond what might be considered a normal period of time, such as a few minutes or beyond the end of the situation itself. These individuals are unable to deal with the situation on their own and often need help from de-escalation techniques to help them return back to that normal state. When we get into phase 4, this is verbally threatening, okay? So this is anger directed towards a specific individual, group, or object. And this indicates that an individual has moved into that phase. So according to Wilder and Sorensen, the authors of that book that I mentioned at the beginning here, look for 1 or 2 distinct red flags to suggest this phase is present. The first one, the individual directs angry statements towards you, such as, you need to go away, they need to apologize to me now, okay? The second red flag is when that individual suggests consequences if the situation doesn't resolve to their liking. Right? So I'm gonna do this if you don't do that. Okay? Absent from phase 4 are those physical actions or movements, such as moving towards a weapon or making fists. It can be distinguished from phase 5 because the individual is making demands towards someone, or is hinting or suggesting at consequences for an inaction without specifying what the consequence might be or having an immediate item to carry out the consequence. And this is also the final phase where us as pre-hospital providers are likely able to intervene and maintain control over a situation. Once we hit phase 5, this is physically threatening. Right? By the time they begin making physical threats, situational control is nearly lost. There is a very real potential for physical harm. So physical threatening individuals often stop voicing demands for action and instead exhibit body language that suggests their next move. So look for a physical stance that anticipates violence, such as a fighting position, making fists, looking for objects that can be used as weapons. At this point, any object that is heavy and or can be thrown may be used as a weapon against us. Okay? How we respond to these individuals greatly determines the next step. If we respond with anger, aggression, or threat, then the individual is more likely to attack. And there are, we got some clues here. So sudden movements towards you, muscle group tightening, twitching facial muscles, darting eye movements, a fixed stare, shifting their balance, increasing their volume, rapid breathing. And the last phase is physically violent. Okay. Once individuals become physically violent, you can, de-escalation attempts stop. All right. And this is when your personal protection and self-defense are going to prevail. If they start to become physically violent, it is essential to not only get out of and end the situation quickly and safely, but whenever practical, there's also a duty to attempt to prevent injury to the aggressive individual as well. And this is where our conscience may come in. It's a very, very difficult paradigm to accept, but personal safety is always, always first, right? So what it does suggest is that the least invasive restraint methods need to be used, especially when you have physical force. And we're going to talk about that here in a couple minutes. So what can we do? So whenever we're caring for an individual, it's not only important to return patients to that calm and non-threatening state, but it's also imperative to not do anything that may escalate the patient's response. So the best way to prevent escalation is to always ensure the patient is being given the very best medical care possible at that time, okay? Respect their dignity, including religious practices, listen to their concerns and their family, and always be compassionate and caring. Okay, those are some of the biggest things that we can do to help people not get upset. And it seems simple, but maintaining that non-judgmental position for anything can be a challenge, for anybody. So verbally agitated patients can often be calmed by following a couple of steps, okay? First and foremost is to listen to them, all right? There is a distinct difference between hearing and listening, right? Listening requires letting the patient finish their train of thought, acknowledging their feelings by not interjecting our own beliefs or thoughts, and reaffirming. And this one statement here can be a lifesaver. After they're done talking, if I understand you correctly, this event makes you feel, or this makes you, this is what, all right? That term, if I understand you correctly, that lets them know that you actually just listened to them and you're going to try and understand what they're trying to say, okay? Don't say, well, I think, or if I were in your shoes, or, my opinion is. They don't care about our opinion. They want us to listen to them. And that's what our job is. Make sure to respect them. How would you want to feel if you were in their shoes? Right? Consider how they'll feel once that event's passed. Remember that this person is having difficulty dealing with the situation, and talking down to them is going to deflate their self-esteem and make the situation worse. Right? So remember that statement, if I understand you correctly. Right? Avoid giving orders. Dictating what an individual must do, particularly in a condescending manner, is more likely to fuel the fire than it is to calm it. Okay? Instead, offer them an opportunity to share what options they see in the situation and ask them what their desired outcome might be. All right, once they share their options, it may be appropriate to share how you can offer support in each of their options, or none. Okay? So don't give orders blatantly. As tempting as it may become, please don't develop that threatening body posture. Don't cross your arms. Don't stand there looking mad when they start becoming verbally hostile. Stay calm and relax. Remain at eye level. If they're sitting, you sit. All right? Don't look down at them. When standing, maintaining that non-threatening position by keeping your hands where they can be seen, shoulders relaxed, speaking softly. Don't yell. Keep a respectful distance. Give yourself that buffer zone. Okay? A safe buffer zone for somebody that's becoming aggressive is 6 feet, but it could be decreased or increased as that situation changes. And when talking to them, listen and let them verbalize their concerns. Avoid directions and instructions, base the options on the patient's actual concerns, and don't threaten them like, oh, I'm going to have to call the police. Okay? That should be one of our last options if they're not already there. Okay. Should somebody exhibit verbally threatening behavior, all right, remain aware that the situation is rapidly changing and de-escalation is going to be more difficult. So as they go through those phases and they get down to phase 4 and phase 5, being able to bring them back is going to become harder. Right? So acting carefully in the beginning can help prevent this situation from worsening. So maintain our eye contact without staring. Okay. Look at the patient in a manner that lets them know you're there for them, but it's not threatening. Keep a soft facial expression. Don't show displeasure, anger, hostility. One trick that I read in the book is to focus on the patient's left eye rather than both, because then it doesn't look like you're staring at them. Okay. And watching the patient's eyes prevents your back from being turned on the patient and allows you to monitor for signs that the patient's beginning to look for stuff. You can see their eyes darting around. Right. Avoid making them feel trapped. Okay. When someone feels trapped, they feel like they've lost control or someone else is trying to control them. An individual may feel physically or psychologically trapped. Physical trapping occurs when exit's blocked and they're backed into a corner, or they believe they're being restrained. Restraint here can be perceived from a gesture as simple as placing a hand on a shoulder. So to avoid this, always gain permission before touching them when they're upset, right? And tell them exactly what you plan to do. Psychological trapping can occur when someone is left believing that they only have 2 options: fight or listen. All right. To avoid that, maintain choices as positives and let the patient believe the decision is theirs to make. Anybody that becomes physically threatening are dangerous, and it's important to recognize when you get to that critical point. A physical response may be needed, but is actually beyond our scope. We should not be fighting with patients. Right? We leave that to other people. We are not trained to properly provide a physical response to somebody. All right. But while interacting with these patients, remember to maintain that non-threatening posture and remain calm. Look for your exit path, okay? Look for that safe withdrawal path and do not allow the patient to get between you and that exit. And if you've not been trained in defensive tactics, withdraw from the scene. If they get to the point where they're going to start becoming violent, you leave, right? Cannot stress that enough. So potentially threatening actions by providers, talking down to somebody, talking loudly, standing over them, staring them down, limiting their options, trapping them, arguing with them, violating their personal space, grabbing the patient without permission. And they also provided a handy list of non-traditional weapons that you might not think of. Ashtrays, pens and pencils, they're good for stabbing, okay? Lamps, extension cords, alcohol bottles, your own equipment, pictures hanging on the walls, canes, walkers, all these things can be a non-traditional weapon that could be used against you. So what does the state of Maryland have to say about this? Well, behavioral emergencies are classified as an action that indicates the patient's mental function is disturbed and may pose a threat to oneself or others. So that could be suicide, a threat of violence, or psychosis. Right? They have this huge alert here. It says the clinician should recognize critical incident stress as a state of emotional distress that does not necessarily pose a threat to oneself or others, i.e. like a death in the family. People are going to be stressed out, right? We should not be placed in any physical jeopardy or assume any law enforcement functions, especially when weapons and or acts of violence are involved. And they put an exclamation point after that. We are not law enforcement. We do not put ourselves in that position. Okay? Law enforcement should be requested on all calls involving potentially violent patients. Okay? So for BLS, when we're considering treatment of these types of patients, restraints, okay? If you have pre-hospital use of restraints, a law enforcement officer should apply the device and accompany the clinician and patient in the ambulance. We're talking about handcuffs here, okay? For interfacility transports, you have to have a physician's order, just in case you're ordering. They also recommend the SAFER model. So stabilize the situation by containing and lowering the stimuli, assess and acknowledge the crisis, facilitate the identification and activation of resources. So whether you need to get a chaplain, a family member, or the police, whatever it may be. Encourage the patient to use resources and take actions in their own best interest. And leave the patient in the care of a responsible person or professional or transport to appropriate facility. And this is what MEMS recommends as our baseline for when dealing with somebody that has some sort of behavioral emergency.
Hey, Jamie, can we go over A again on the treatment? Because in here it says the officer should apply, I agree with that, devices and accompany the clinician and the patient to in the ambulance. But if they put the handcuffs, they must be in the ambulance then.
Absolutely.
Right, but I'm just reading a statement how it's kind of vague. It starts out should.
In the event of a BLS provider using restraints, if it has gotten to that point,
right,
you need someone other than the BLS provider.
No, I guess my point was that, yes, the officer should, yeah, we agree with that, but it seems like it should say must accompany the clinician and the patient.
It's not a requirement, it is a strong recommendation.
There you go, okay, I thought it was a requirement.
It's a strong recommendation.
Okay, got it.
When you jump into ALS, we have a couple other things we can do. We have both physical and chemical restraint methods. Okay, the purpose of this is to prevent harm to the patient and others. So these should be measures of last resort. Okay, so patient restraints, physical or chemical, should be utilized only when necessary and only in situations where the patient is exhibiting behavior that the EMS clinician believes will present a danger to the patient or others. We don't just walk around sticking people with needles and knocking them unconscious. Right? So, physical restraint procedure, patients have to be older.
What if law enforcement requests it?
I'll get to that.
Oh, cool.
Yeah. Okay. Um,
It's not
physical
even a
restraint.
case on it or anything.
Oh yeah, that's a whole reason about something that's about 3 slides after this one. um, so with physical restraints, patient has to be over the year of age. Make sure you're seen safe. Ensure that sufficient personnel are present to control the patient while restraining and use police assistance whenever available. And make sure the patient is safe for transport. So we do not put restraints on somebody and put them face down on the cot. That's not how this works. Okay, when we're applying restraints, one arm up, one arm down, and the ankles. Right. All right, so patient positioning should be modified when restraining patients with limited mobility, i.e. if they're confined to a bed or wheelchair. Passive restraint and place the patients with a previous injury or pre-existing conditions like osteoporosis or something in a more neutral position. They are not to be restrained in a prone, hobbled, or hog-tied position. All right. All patients who are physically restrained and continue to fight their restraints should be considered for chemical restraints. Okay, so face up or on their side, secure the extremities. We want to use 4 points. Ideally, like I said, one arm up, opposite side down, or use a sheet to carefully wrap the patient before applying a Reeves type stretcher. They actually still recommend that. It's crazy, right? Anybody for 12 and under, use a 3-point restraint, 2 arms and 1 leg. If police handcuff the patient, jointly with police, reposition the patient in a face-up position with hands anterior and secured to the stretcher. Okay. We can use cervical spine precautions to control violent head movements. Okay. Patient padding under their head, any other areas that need to prevent the patient from further harming themselves. And then we're going to secure the patient to the stretcher using additional straps if necessary, and be prepared at all times to log roll suction and maintain that airway in case they do vomit or get obstruction. We're constantly going to monitor their airway. They have to be on pulse oximetry when available, distal neurocirculatory status distal to the restraints to make sure we haven't cut off circulation. We're going to document the findings every 15 minutes along with the reason for restraining. You can't just restrain somebody. You have to have a valid reason. Okay. So note, this one right here is not for excited delirium. That is something completely different. Okay. So I would use this combination here in somebody, maybe we have an elderly dementia patient that's fighting. I think Dave and I had a patient a couple years ago where this woman was half naked trying to put a metal coat hanger in a wall socket. She was obviously mentally altered due to dementia. And we had to use a little chemical restraint to help us with the situation. So as a paramedic, we can give midazolam and haloperidol. Okay. And they have different dosages depending on the age, like most meds. Excited delirium is very specific, and we'll get to that in a second. We can do this for pediatric patients, and we're going to do haloperidol only. We have to get an IV access. We want to use a glucometer, vital signs. If we have any acute dystonic or extrapyramidal reactions with it, we can give diphenhydramine, and again, monitoring that airway continuously throughout transport.
I've got a question there, Jamie. Is the diphenhydramine still is that a consult?
No, this is not a consult. This is if you have an acute dystonic or extrapyramidal. So if you can document that you have that reaction, you do not need to consult in that situation.
Right, because you used to have to consult for it, but
used to, yes. But you have to be able to. You have those specific things going on.
Yeah. Okay.
There's some big words there. I know diphenhydramine is Benadryl, but the dystonic and extrapyramidal, what are those?
Dave, you want to take this? You've experienced this quite a few times.
Sure, not me personally. Okay, so mild dystonic reaction is facial twitching. So let me back up a little bit. So Haldol or haloperidol is a drug which will cause things called dystonic reaction. And dystonic reactions can be mild or they can be extreme. From one end to the other, facial twitching, so somebody develops a twitch literally kind of a almost like an eye twitch, a blink. Maybe they'll bring their bottom jaw up, right? That sort of thing. You think, what the hell? And they're just making faces, but they're not. It's completely autonomic. They don't have any choice. That's what happens. You may find other limbs twitching, and the first time you see it, even though you've been trained to look for it, it's like, I will tell you now, it's just weird. It's like, what the hell? What's going on?
You look at it, you know, did that just happen? What?
Yeah, exactly. Is something? I mean, you don't know if they do it. Because when you see that, right, particularly when it's a facial expression, you kind of wonder whether it's the person making a face or whether they're doing it autonomically. The middle ground, and the one that is probably the best giveaway, is if they start grinding their teeth.
Mm-hmm.
So what happens is their jaw clenches, and they literally will grate their teeth. I can't even do it when I try to do it, but you actually find they grate their teeth, and you can hear this grating of teeth, and that is a classic, right? That's absolutely a dystonic reaction. It's usually a precursor to an extreme dystonic reaction. And the best description of an extreme dystonic reaction is that they wrap themselves up into a pretzel. They have no control over their muscles. They have no control over the strength of their muscles, or their muscles reacting against each other. So, you know, all muscles contract.
So antagonistic muscle activation.
Say again?
Antagonistic muscle activation. So this is going from twitching to spasming on both sides of a movement.
Extreme spasming. I mean, to the point where they can seriously injure themselves, and they have no control over it. And imagine the worst cramp that you've ever had, and then multiply it by 100.
Yeah. Okay.
So it's very disturbing. It really is. It's quite disturbing. So it's actually quite important. And I personally have developed an attitude. I used to give Haldol. I didn't really. I just used to follow my nose, and if the protocol said do it, do it. And I wasn't really worried about it. It's like, what could possibly go wrong? And I learned that Haldol is my least favorite drug that we have.
Mm-hmm.
It's my most unpredictable, and my least favorite. So I am very, very cautious about giving Haldol. Very cautious. So I urge you to be careful about that. And if you do give it, be prepared to give 5 and 5 of midazolam to go with it, and be prepared to give 25 to 50 of Benadryl. Don't even think you're not going to. When they do this in hospital, they actually have, you know, they kind of have one of these mental rotes, I guess.
5-5-25.
5-25. Give them 5-5-25, right? So you have a patient that's in that mode where you need to give them something to get rid of that psychotic reaction, and they do 5-5-25, and they'll tell the nurse do 5-5-25, and what they mean is 5 of Haldol, 5 of midazolam, and 25 of Benadryl, and they don't even question whether to give the Benadryl or not. I got looked up by a doctor in Charles Regional because I'd given 5 and 5, which is what our protocols at the time allowed.
And
I hadn't given the Benadryl, and he's like, "What are you thinking?" And I'm like, "First, you need to read the protocols that we have to work to. We're not allowed to do that." And at the time, we weren't. So I learned after that I always, when I was going to do that, I'll consult and request. I used to consult and say, "Can I have permission for 25 of Benadryl, 25 to 50 of Benadryl, in the event that I get a dystonic reaction. And then they would immediately say yes. And then I knew that I was clear to do it. Now you don't have to ask.
Okay. Yeah, I mean, the side effects and stuff of Benadryl, from what I understand, are relatively minor compared to like what it does when it's supposed to be working. So it's almost like just push it just because.
Well,
Granted, I'm basic, so I'll probably just recognize this as it happens.
right. I mean, Benadryl, if you give it in increments over 25 milligrams, actually doubles as a muscle relaxer. It's one of those unintended side effects, which is why it's one of the things that we can give, because it's practically safe in just about everybody. Obviously, there are some people that will have reactions to it, but it is a very benign drug that gets the desired effect that we want.
Mm-hmm.
And it's the difference between you get these, you can very often you can guide your treatment to kind of drive your patient in the direction you want them to go. In this particular case, this is a T-junction, right? You can turn left or right. If you do it right, then you end up with a calm, relaxed, sleepy patient. If you do it wrong, then you end up with somebody who you cause enormous amounts of stress and pain and actually personal guilt. I mean, actually thinking that, well, you gave somebody something that turned them into it's horrible. It really is. So that's my only advice.
Okay. So what, do you just push to 25 and then just like have the extra up to 50 just available, or how do you handle that?
Well, in here, adult is anywhere from 25 to 50. I would do 25 and get a second 25 ready just in case.
Yeah.
You can give that IV or IM. At this point, I would prefer IV because it's going to act quicker. But if I got to shoot it in their arm, it's going to hurt. But it is what it is. For pediatrics, we give 1 milligram per kilogram, so there's no like buffer there. We have a maximum dose of 25 total.
Easy enough. All right, thanks.
And anything after that, after you've maxed out those doses, you can get additional with consultation. But we're so close to most of our facilities around here, you're not going to have time for that kind of stuff.
So the other thing is, it may not be you giving it. So we used to have at the at 11100 Billingsley Road, what is now the recovery center, before they turned into a classy organization that actually knows what they're doing. They used to have a pretty low grade drug rehabilitation program there, and a lot of those folks who were being treated had psychosis and psychotic episodes, and the doctor, who bopped in for like half an hour and made a lot of money and popped away again, had a very nasty habit of prescribing Haldol in large quantities. I mean, like, everybody got Haldol. It was like Wheaties. And we would get days where the doctor had visited maybe 4 or 5 hours earlier, and you would literally get one psychotic patient after another, like multiple calls back to back to back. Until I actually walked up there, went up there one day and went in and said, "Can I see him?" And I said, with all due respect, doctor, fill you together. So realize that we have to deal with these patients. So can you please reconsider your treatment protocol? And he actually popped after that.
So actually, that brings up another question too, because Jamie brings up the point, we're so close to our hospitals, and you're talking about 4 or 5 hours later. So I don't know if it was like 31 minutes after he gave the dose, they started acting up, and it just got bad enough they called you, or like what's the progression and timeline on these things? And how fast do I have to act or run away, depending on what's going on?
Usually within within 5 to 10, Dave.
Yeah, I think typically within 5 to 10 is my experience. I mean, I guess one of the most notable ones, I picked up a young person. I think he was about like 19, 20. He had a history of psychosis, but he functioned quite normally. And he'd gone out with the family for dinner at Olive Garden, and something triggered him, and I was called, and I they didn't, I'm like, can you give me some history? Well, I guess they were in the middle of, they don't feel like saying, yes, he has a history of psychosis or psychotic behavior. And they said, no, we don't know what's wrong with him. And I went through all the normal things because he was reacting almost like a diabetic patient. And no, his blood sugar was good, and he'd eaten a couple of spoonfuls of macaroni, so he wasn't going to have low blood sugar. So it's like, okay, well, we'll take you to the hospital. And he obviously was reduced mental capacity, right? And put him in the back of the ambulance. Suddenly he starts spinning up and going into a dystonic state. And we hadn't left Olive Garden. And I stuck my head out the door, and his sister was still there. I said, have you given him Haldol? And he's like, oh, yeah, he's prescribed Haldol.
Like, oopsie.
Okay, now we know what's wrong.
Right.
Anyway, there you go. Sorry to take so long.
I drag that out. Thanks a lot, guys. Appreciate your patience.
No, nothing's ever dragged out here. All right, so excited delirium. This is very specific. So who here knows what excited delirium is? Let's start with that. Other than Dave.
I'm going to go with naked guy with 15 taser darts in him in the middle of in the middle of the gas station.
Wawa parking lot.
Yeah, there you go. That's what I'm going to go with. That's my characterization.
So excited delirium is a potentially life-threatening condition in which a person is in a psychotic and extremely agitated state. All right. Mentally, they are unable to process rational thoughts or to focus their attention. Physically, the body's systems are functioning at such a high rate, they begin to shut down and fail. All right, so when these two things happen at the same time, a person can act erratically enough that they become a danger to themselves and to the public. So, history of this, things that'll clue you into being excited delirium: ingestion of a stimulant or hallucinogenic drug, PCP. Okay, drug or alcohol withdrawal. So if somebody's going through the DTs from alcohol, a psychiatric patient who is no longer medicated, and normally is. Okay. Signs and symptoms you'll see: tachycardia, hypertension, high body temperature. That's ding, ding, ding right there. Dilated pupils. Pinpoint, big ones, big pupils, dilated. Okay. Incoherent or nonsensical speech, rapid, inconsistent breathing patterns, paranoia, changes in the skin. They could be hot, dry skin in anticholinergic patients, or profuse sweating. When you see cocaine, MDMA, methamphetamines, you'll see sweating. Shivering, inappropriate removal of clothing.
I was going to say we could make it in here somewhere.
Are patients who present after receiving multiple taser or other less lethal energy by law enforcement. So if they've been tased multiple times, it can create this situation. All right. Things that look similar to excited delirium. All right. Hypoglycemia, hypoxia, seizures, head injuries, and sepsis. All right, those things can mimic some of the excited delirium symptoms. So we always want to make sure to get a thorough history before we go down this path. Okay. And it's a key symptom that occurs just prior to the onset of sudden death in this patient, because that's what we're trying to avoid here, sudden death. Okay, is instant tranquility. So if you haven't given them medication and they are all hyped up, stripping naked, acting like a fool, and all of a sudden they come to peace with Jesus and sit there in the middle of the floor and go, oh, I feel so much better, that is a sign of impending doom, and they might be getting ready to die. All right, so the instant they become tranquil, please, please, please. All right, that is a sign of imminent cardiopulmonary arrest. All right. Patients who have undergone periods of prolonged physical struggle without sedation with medication are at a high risk for cardiac arrest. So all efforts must be made by our ALS clinicians to expeditiously administer medication to the agitated and struggling excited delirium patient. All right, with that being said, for BLS, we are going to ensure the scene is safe. All right, if they are actively tasing your patient, don't go touch them. Okay, let them do what they're doing. Okay, so
Yes,
we're going
being tased.
right. We're going to initiate patient care. You're going to get a temperature because these patients often have hyperthermia. If possible, attempt to identify the amount, route, and any time of substance ingested. Suspected EXDS patients with evidence of head injury or traumatic mechanism of injury should receive spinal protection protocol. Any patient displaying the signs of this do not have the medical capacity to refuse your care. If you show up, they're coming with you or somebody very similar to you. Okay, they're going in an ambulance. Right. If they resist the delivery of care, ALS resources, EMS supervisors available, law enforcement shall be requested to facilitate the treatment and transport of the patient in a safe and effective manner. If they get violent, you were required to have a police officer accompany you. Okay? So, any patient displaying signs and symptoms of this shall be treated and transported at the advanced life support level. ALS care and treatment will be guided by the signs and symptoms that the patient is exhibiting. Okay? As well as the possible occult injuries that may have occurred while the individual was being subdued. So, quick question. Are we allowed to remove taser darts?
Depends who you ask.
Always thought no. That's true.
A taser dart is technically an impaled object.
If you're a tactical medic, you can.
Well, yes. For the rest of us in the group here, David, we are not tactical medics. We are not allowed to remove them. However, a well-placed foot on the ground on top of some wires, they may accidentally fall out. Just saying. But yeah, we don't remove tasers. So the appropriate life-saving treatment for excited delirium is the administration of medication, fluid resuscitation, and decreasing hyperthermic core body temperature. Right. People that have received multiple rounds of energy from conducted electrical weapons and are displaying signs of this are at a heightened risk for that sudden cardiac death, and they should be treated with medication and closely monitored for any evidence of hemodynamic collapse. Right. So that's the overview. Here's the fun stuff. All right, so our drug of choice is ketamine, okay? IVIO access, we don't do blood draws. We're gonna give them 20 milliliter per kilogram fluid if tachycardic and or hyperthermic. Check their glucose, and we can give some ketamine. So 1 milligram per kilogram, maximum single dose is 100 milligrams. If severe agitation persists, administer another one, okay? After the second dose, consider midazolam. If it's unavailable, we can administer it IM, right? If we don't have an IV in place. Now, with that being said, you'll see the bigger picture here because there was a directive from the state medical director a few weeks ago. So there are some changes because, and this is, Rohan, this is where I'm going to introduce what you're saying. What if the police ask us to? Well, there's the problem. So across the country, police know we carry this drug. And they have been like, oh, I don't feel like dealing with this patient. Can you just knock him out? Okay. And providers with very poor judgment have been doing that. And people have actually died. So the provider gives the ketamine, they go into police custody, the patient dies. And with all of the...
Are we required to like take custody of the patient once we administer any treatment? Oh, okay. I wasn't sure if that maybe protocol or something.
Yes. These are great. So with everything going on in the world today, and with the different changing climates with police and things like that, Maryland has decided to be proactive. We had not had this situation in our state, but now they are saying that if we want to give ketamine, we have to get a consult unless the patient is actively aggressive and violent. And when I look at that situation, I'm not really upset by it because if the patient is that violent, I'm probably going to need to sedate them anyway. If they are not violent, if they're just agitated and you can talk to them, they probably didn't need it. So they advise us that we want to use de-escalation techniques, look at the risks versus the benefits. We may not accept orders or requests from law enforcement officers. Just because they want it, we don't have to give it. It's my drugs. I'm not giving them to anybody unless I want to. All right. So online medical direction must be obtained prior to giving ketamine for severe agitation unless doing so would present immediate and imminent harm to the patient or clinician. If you give them ketamine, they have to be transported in a supine position. Okay. Can't put them under a backboard, can't lay them flat. At least 2 EMS clinicians, at least 1 of ALS must directly care for the patient during transport. All right. 2 ALS clinicians are recommended, but if you have an ALS and a BLS, that suffice. You must have 2 people in the back of the unit. No ifs, ands, or buts. The patient may not be transported by BLS alone or law enforcement. Right. We have to monitor them. Pulse oximetry, ETCO2, cardiac monitoring must be initiated at the earliest possible time after ketamine is given. All right. Advanced airway equipment, bag valve mask, ventilation, and oxygen must be immediately available for any patient receiving ketamine. One-line medical direction must be obtained from a midazolam if a prior dose of ketamine was administered. Right. And if you give it, you're going for a review. They've just given you a blanket statement. So if you give ketamine, the jurisdictional medical director must review all cases in which it's been given for severe agitation. So you're going to be having a chat with somebody. They're looking at updating the protocol. And like I said, this is all driven because there were very bad judgments made by very poor providers where they dosed people with this drug and the patient subsequently died because they were given the wrong dosage and were not monitored properly. Because every drug has a side effect. With ketamine, one of those side effects can be death because it can compromise your airway. So Maryland is being proactive and asking us to take a step back and try to de-escalate the situation and only use this drug if absolutely needed and there's no other options. Does that make sense?
Hey, Chief, just a question for you there. In a very practical way, if you arrive on the scene, the ALS provider, and, in the past, as you mentioned, the police just said, hey, just give them a shot of ketamine. Could it be that the situation, the person is still, sorry, I had the question in mind now, it's kind of passed me by. But essentially, I think what I'm trying to get at is if the person still may be upset or fairly hyped up, especially if police are asking to administer it. I would imagine, even if we don't determine that even if we were to arrive on the scene and notice that the patient was, remarkably calm, the police may still say, well, no, this person was like this and this person was violent and combative. It just seems like it would, for the provider, for us, or the clinician, that we would need to have the courage to say, no, let me take a look at this situation. It seems like the de-escalation technique would be odd in that particular, situation.
So I kind of get what you're saying, that we can arrive on scene because the police have requested us because this person is out of control. All right. We present a different option to that patient. Remember earlier I was talking about giving them options?
Right,
Sometimes some people will react very specifically when placed in front of a law enforcement officer. They will react completely differently when placed in front of somebody that is there to listen and wants to take care of them. So our ability to come in and be that calmer voice and talk to them when it is possible to de-escalate them down to a calm situation, they may willingly come with us. And if the officer says, well, they were just doing this, you need to give them ketamine, I'm going to look right at that officer. I don't give a crap who it is. And I'm going to tell him, well, you've called me. This is now my patient. And I do not feel that they need this drug. They are acting respectful to me. They are being fine. They're getting in my ambulance with no problems. Please follow me to the hospital.
Fair enough. Like that particular point just made me think that, the officer who called you to the scene may feel some type of way being presented like that. Even if what we're saying is 100% correct. It seems like they would be, that they, may get into their feelings over the fact that we're attempting de-escalation where they perhaps were not successful or didn't do.
Daryl,
And that is very true.
to
Yeah,
be honest,
Daryl, you bring up a point because you're de-escalating the situation in two levels with the cop and with the patient, right?
Mm-hmm.
And I think Jamie will agree with this. You treat the patient, not the history, and not the instrument. So, I mean, one of the negotiation tactics or whatever I want to call it, I learned is you can promise to consider instead of promising to deliver. So if they say, "Hey, hit him with this," you'll be like, "All right, yeah, I'll do that if he needs it," and then just to not yet, not yet, not yet. He's in your ambulance, the cop's somewhere else. It doesn't matter, so you can kind of avoid that fight without any issues.
And not only that, we actually have a police officer that comes to our monthly chiefs meeting that we have abilities to talk with so that we can discuss these things. And we actually have a really good relationship with the sheriff's department, and we have a really good respectful relationship. So, and Patrice mentioned in the chat, our responsibility is more to our patient. That is correct. Our responsibility is to the patient and providing quality patient care. It is not to that officer. And if they want to have a little tissy fit, they can go have a tissy fit by themselves. I really don't care.
so I'll give you 3 examples, and they're all different, and each one carries a message, and you can work out what the message is. So, first example, agitated patient clearly has some sort of substance on board, turned out to be PCP. Normally PCP is involved one way or another in a lot of these things. But still could communicate. So in other words, the patient was agitated but communicative, right? He basically could tell me to go F myself, right? So that's I consider that communication. So the fact that he even recognizes that I'm there as a human being means that I've got a gateway to be able to talk to that patient. Under those circumstances, because he'd already been arrested and the police were coming in the back of the ambulance, that patient was handcuffed onto a stretcher, right? So they were handcuffed because they'd already smacked one of the police in the face. During the process, the police officer, bearing in mind that he's got a handcuffed patient, because the patient was being mouthy, which I don't care about, he's my patient, tased the patient. Clearly escalating the situation.
Ooh, I'd have gone off.
I did.
Good.
So that's the first example, right? You've got a patient that you can control, but you've got an angry police officer, not angry with me, angry with the fact that he's been smacked in the face. What do you do about that? Well, you document it and you try and control the situation as best you can reasonably control it. And I've told police officers, this is my patient, you're here to protect me, back off, right? Back off and give me space. In that particular case, the police officer was extreme. Second case, I arrived at the same time as a state trooper. The patient was in a car. He was not coming out of the car. The car was in a... The police officer tried to get him out of the car. And in the process of trying to get him out of the car, the patient tried to rip his throat out with his teeth. The state trooper was extremely frightened, and reacted, drew his weapon, and was going to shoot the patient.
I think this is the one I yelled at you for.
Right. And I said to the police officer, I said, sir, officer, let me deal with him. Back off, give me some space. If he goes for me, then you can shoot him. But don't shoot him just because he went for you. Right? I can deal with this. I just need enough time. And we set it up so that the patient wasn't going anywhere. He was in his car.
Wasn't he pinned against a tree? He had wrecked into a tree, so he technically couldn't get out without help.
The car was pinned against a tree and he was backed into the car, so you couldn't get him without going into the car. And I set up to sedate, but I'd got a BLS crew which was completely set up for resuscitation. And I put my body armor on, my helmet on, because I knew that he would go for me as soon as I went in there. He was not communicative. He would not. It wasn't possible. The only way that patient was coming out of that car, other than in a body bag, was to be sedated. It was successful, no problem at all. We got him out. But it meant being at risk in the process. But I would rather be at risk and do that, personally speaking, that's my choice, appropriately protected in an organized, controlled way, to give him a sedative so that he doesn't have to be shot, because they were going to shoot him. There wasn't going to be any doubt about that at all. And the third one was, again,
Wait a second. Wait, hold on 1 sec, Dave. I just want everybody to mentally envision Dave as a ninja with a ketamine dart.
that's right. Yes. And the third, and there's been like quite a few of these, but the third example of, and you've just heard what happens if you use excessive energy and multiple discharges. We arrived on, and it was the patient in the middle of the gas station, naked, with, I think at that point he got 8 darts in him, and that hadn't even slowed him down. Maisha, of all people,
Oh,
right,
Jesus.
who's a pretty tough lady, I said, "Do you want me to deal with this?" She's, "No, I've got this." Right, and she told the police to back off. She went and the patient was communicative, and she got him to walk to the ambulance, sit in the ambulance, and he was cuffed to the stretcher. I was driving, and I got asked by dispatch, "Do you want a tactical medic here when you get here to take taser darts out?" Maisha overheard it, and she said, "No, we're still using them." So, I mean, that's a whole spectrum. And the key to me is, does the patient recognize me as a human being? And can I negotiate with the patient? I don't mean in a soft way, but I mean in a way that I can get them to channel their activities to listen to me and concentrate and get everybody else out of the way, to stop them being distracted and getting angry because they're surrounded by a bunch of police. One last thing. Sorry, I'm going to say this because I'm kind of good at this. There is one thing, and I guess I learned this the wrong way, where it is very common, and I think it's become more common more recently, where PCP and heroin are taken together.
Oh, yeah.
And we're all keen, we love that heroin call, right? Because they've got pinpoint pupils, and we're going to save a life, and oh my God, how good it is. That and solving diabetic emergencies. We love doing that because we get instant results. Well, if you didn't know the patient has taken a PCP opiate mix, and you remove the sedative that's doing a perfectly good job of keeping the PCP under control, and you remove it, what you've just done is you've offset the sedative, and now you've got raw PCP, except that you've now got it in the back of your ambulance and you're on your own.
And that's why I don't wake up my heroin overdoses, because I can bag them all day long.
And that what Jamie just said is the overuse of Narcan, particularly by police officers, is ludicrous, because it puts us in a position, particularly if they've got an underlying PCP, it puts us in a position where now we've got at the minimum an angry, vomiting patient, and at worst we've actually got a PCP aggravated patient, and now we can't sedate them because they've got Narcan on board. So no matter what we do, it's not going to help. So those are 4 different examples of what start off as an excited delirium call. But Patrice had got it absolutely right? Our patient is what we listen to and watch and read. We do not listen to, we can listen to anybody we want to, but we do not, we don't get told by the police, no matter what they are, that we will or won't take a particular medical course of action. If we choose to take a medical course of action, it's because it's the right thing for our patient. And sometimes that means protecting our patient, and I will say somewhat at risk. And I know that's inappropriate because we're told not to do that. But if it's the difference between my patient being saved from a situation which would ultimately result in their death and taking no action at all, I would rather act. And I think it's that, but do it thoughtfully.
That is
Right.
absolutely. And, you know, I can't stress enough that safety is our number one priority here. Is the scene safe? Has something changed? When you go onto scenes with potentially violent people, your head needs to be on a swivel. You need to be watching your surroundings, looking for people that are walking in and out of the scene, looking at their demeanor, watching your patient, looking for your crew. You know, if you get into a situation, there's that lovely red button on that radio. Okay. You don't have to say anything special. Hit the button and start talking. I don't care what you say. You know, hit that button, start describing what's going on and going around, and get the heck out of there. Right.
And if you've got a group of people, you know, it isn't just necessarily PCP or drugs like that. It can be just somebody agitated with alcohol, right? And then if you've got half a dozen people who are agitated with alcohol, and you're watching the one that you were brought to, you know, deal with, in the sense of we've got a patient that's unconscious or unable to even walk or communicate, or in some way medically compromised to the point of putting themselves at risk. Watch out for the other five. One of the closest calls I've had is myself and my partner were concentrating on the patient, and one of their buds decided that they were going to help. They got in their car and tried to crush us between their car and our ambulance. And they missed us by a hair. I mean, they literally drove their car straight into our ambulance, trying to pin us. And they came very close to doing it. And that would have been two of us. So it's really, really difficult to come up with one set of rules that say for all situations, but you have to just be very, very aware. And if there's two of you, one watches the patient, the other watches everything else.
Yep. Absolutely. Absolutely. Safety, safety, safety. All right. So I thought this was funny. Ha 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 ha. So the big point to take away from this is we as clinicians have the ability to be very powerful in our own rights, as long as we can maintain that calm, because we are seen as the people that are there to take care of you. We are here to help you. We are your new best friends, right? We are here to try and make everything better. As long as we can maintain our calm, you can be screaming on the inside. That's cool. Your face, you've got to get this facial expression thing down to where you are having this era of calm. You're not raising your voice. You're not making snappy remarks. And you can make the difference between that patient getting what they need in an expedited fashion or getting what they need delayed after we've done a bunch of stuff that they really didn't need. So we have to be empathetic. We have to be good listeners. And we have to care about what we're doing.
Patrice asked a question, which is, do the police always tell you whether they're given Narcan or not? Well, the answer to that is just assume that they have, because they love that. I remember saying to Sheriff Berry at a dinner at one point, something along the lines of, you know, you guys can give Narcan, you've delivered a baby or two, what else? You won't need us soon.
Right.
And you know, God bless it, they rush in with Narcan. If you've got a breathing patient who is protecting their own airway, why do we insist on spoiling their whole day, right? It's absolutely not necessary. And they've already sedated themselves. Unless they go into a position where they can't protect their own airway, there's really no reason for us to actually administer.
And
We don't.
Yeah. And there's a secondary thing there. So what is our dose of Narcan initially?
One on one up each nose.
So
Okay.
2 milligrams total, right?
Yeah.
Police don't do that. They give you 4 milligrams all at once. All right. And then when it doesn't work like this, they get their buddy to grab theirs and they give another 4 milligrams. So now they have 8 milligrams on board.
That's right.
There are actually bad reactions from giving too much Narcan.
They're
You can
drowned
have
up.
flash pulmonary edema, where the patient will actually start having real problems breathing because their lungs have filled with fluid because of the rapid administration of way too much Narcan. Which is why when I give Narcan, yeah, I can do 1 and 1. I'm going to do like 0.5, and I will wait a second. I'm going to do another 0.5, and I'm going to wait a second. And if they start breathing on their own, great. Don't wake them up. Unless you really have a disdain for the nurse in the ER and you want them to wake up as soon as they walk through the doors, you can slam it on the way in. But, you know, don't wake them up. I mean, I had a situation. Right. And Barry was on this call where it was a BLS. The woman was drunk or unconscious over behind the old Burger King by the mall. And BLS crew got there and, you know, within 5 minutes of them calling, getting on scene, they're like, we need ALS. Patient's now unconscious. And, you know, so I drive over there and I get there and the patient is indeed unconscious and she had been drinking and no one could tell me if she'd been doing drugs or whatever it may be. And we get her in the back of the ambulance. She's unconscious. I've sternal rubbed her. We've Narcaned her. She ain't doing nothing. She's having apneic periods. Okay. Well, this is another drug combination that's fun later in life. So large quantities of alcohol, low dose PCP, does the same thing as heroin and PCP. So she went into the hospital smelling like a drunk tank, and Dr. Ginsburg was like, oh, she's drunk. Just put her down there. She'll wake up in a bit. I think Barry and I got there, what, an hour and a half later, and she was running around half naked because the alcohol went off and the PCP because he didn't want to believe me that she was going apneic on us or that stuff was happening.
I mean, that's a perfect case. And I mean, so you're hearing a lot of the ALS cases. There's been a lot of BLS cases. The same thing is, you know, you come, like there's a perfect drunk. We thought it was a perfect drunk. And I'll be honest with you that, I mean, that's the first thing we assumed. Then when we came back and they're running around screaming through the hallways butt naked, well, you know, bingo, this PCP. And I can tell you there's been a lot of BLS calls. I've been dealing with PCP and some playing flat out nuts. And
That's right. You were there, Michaela.
I actually had, this is one that had nothing to do with drugs. This is an elderly lady who cut herself on the head and went ballistic on us. And Dave actually was there at the time. I was actually doing my EMT, assessments.
Ooh,
And she started screaming, yelling at us. And all of a sudden I turned around and all my trainers walked away and left me alone. I'm like, wait a minute. And she locked herself in the bathroom and screamed and cussed, and you know, it was a whole nightmare.
And sometimes it may just take putting someone else in the room.
Right.
Change your face. If you're not making progress, let somebody else try.
And sometimes change if you're a male, change to a female provider. Yeah, I mean, or vice versa.
You know, I'm sorry, Chief.
No, go for it.
I was going to say, you know, we not to be afraid if, you know, if the OIC or the primary provider on the scene is having difficulty de-escalating a situation, don't be afraid to, you know, to jump in and assist, because sometimes the primary provider, you know, sometimes people will say things that really get under people's skin. I've had a few calls like that in my time of volunteering. Once when I was a ride along, I was actually just a ride along, and the career firefighter was getting cursed out by someone, getting called every name in the book, you know, talked about the man's mama and grandmama and everyone else. And he was really getting riled up. And essentially just say, why don't you leave? And because he wasn't riled up at me or the other person. So we were able to help defuse the situation. And I've been on calls like that similarly, where someone may say something. In fact, I think Barry and I were on a call, and maybe Victoria, where the gentleman got really riled up and upset. He got riled up at the police, he got riled up at everyone. And I just said something like, hey, you know, just calm down and sit on a cot. And next thing you know, he's like, you know, your mama's this, you know. So so not to be afraid of helping out our partners is essentially what I was trying to mention.
Absolutely, absolutely. Because we all have patients that try our patients that try our patients. You know, if you've been to the same patient for the same exact thing, the third shift in a row, less than 12 hours apart, and they've overdosed again or they've done something stupid again, and you have that frustration, don't let it show. Go curse them out in the ambulance when you're by yourself. You know, go to
Right.
the, don't let the patient see your frustration. You need to have that calm demeanor, and you can diffuse probably a majority of your bad situations.
And if I have a